I'm looking at that chat there. Right, okay, shall we go? Do we clash? Yes. Great, gosh. Okay, can everyone hear me? Can you wave if you can't? Right, okay, hi. I'm Mary Elford. I'm Vice Chair of the Trust, East London Foundation Trust. I'm here to welcome you. I'm also here to explain that I'm not Marie Gabriel, who is the Chair of East London Foundation Trust. And sadly, Marie couldn't be with us today. She's got some mobility issues, but she was very keen that I send her good wishes to you all today. So lots of opportunities to welcome people today. We've got about 200 people joining us this morning, a mix of service users, staff, commissioners, two very important visitors as well, coming to speak to you later. Chris Hamm, who is the Chief Executive of the King's Fund, and also Pedro Delgado, who is here somewhere in the audience. Can you wave, Pedro? And Pedro is the head of the IHI for Europe and Latin America. He'll be speaking to us later. And as many of you know, the IHI have been key partners in our quality improvement work so far. So it's a great opportunity today to celebrate what we've achieved so far, a year of fantastic progress with QI in Luton and Bedfordshire. A chance to look forward, but also a chance to look back for Luton and Bedfordshire, for East London, for the people who work for East London, the people who are part of the Trust, our service users. It's been the most incredible year, a year where we achieved the outstanding rating from the CQC, one of only 2 mental health and community trusts to achieve that. We also achieved Trust of the Year with the HSJ. I think, again, the first mental health trust that had ever achieved that rating, Trust of the Year. So an amazing year to look back on whilst we plan our quality improvement journey for the next year. But also a year of sadness. As many of you know, our much loved Chief Executive, Robert Dolan, died shortly after retiring last year. Robert was very much the architect of where East London is today, and also of the move to Luton and Bedfordshire. It was something he was absolutely passionate about and really encouraged us as a board to move to Luton and Bedfordshire, and could really see the synergy between the services and the service users and the staff in Luton and Bedfordshire and ELFT. So it's an opportunity to reflect on that. And also the pride he would have taken in the progress that has been made in the short time that we have been with Luton and Bedfordshire. But the other thing that would have given him huge pride is the fact that standing to my left is Dr. Navina Evans, who is our new Chief Executive. And it's with great pleasure that I hand over to her. Navina.
Thank you, Mary. Well, this is wonderful. There's so many people, great venue. And was it a quick PDSA effort to fix the kit? So it works. It does work. I want to just say a huge thank you to all the staff and service users in Bedfordshire and Luton. It's been amazing. In April, it'll be the start of the 3rd year of our relationship. And I think it's the best thing that we ever did. This move to Bedfordshire and Luton. So much to learn, so much sort of rich experience and commitment. It's really wonderful. And that level of commitment here was definitely recognised by the CQC. They certainly picked it out as something really rather wonderful. Also, the way in which our colleagues here, staff and service users, have embraced the QI kind of work at a pace which is quite something, and especially when we were used to sort of how we had to kind of really get into it in East London. It's just been fantastic, so thank you all so much. You might know that the results of the staff survey for this last year are out today, and we have the best staff engagement score in this trust of all mental health and community trusts in the country. So again, thank you for your willingness to engage and to really think about how we can do things differently to keep improving the experience that our service users and their carers have with us. So today, I'm really looking forward to today. It's very exciting. As Oz said, there's a live stream, but there's also a love stream. I really like that. It's a celebration of everybody's hard work. I think that it's the sort of, we're well on our way to embedding improvement in everything we do. And when we think about improvement, it gives us lots of hope for what we can do for our service users, but also for the population that we serve at large. So I think it's a really good day, and I look forward to learning quite a lot from everybody here, all our colleagues, about what we need to do next to keep on that journey of improvement. Thank you.
Thanks, Navina and Mary. Just wanted to introduce you to a couple of the technological things we'll be using today at the conference. As Navina mentioned, we are live streaming, so there's a camera at the back that's capturing everything, so if you want to wave to everyone at home on your way past later on. Secondly, we're using Slido again, which we used at the conference last year. So Slido is an interactive conference tool that allows you to access the conference on your phones and tablets or computers if you're watching at home. It'll enable you to ask questions during the event, to vote in live polls, which we'll have going on later, to view a copy of the slides which are uploaded to there, and it also enables you to access your Twitter account so you can send tweets directly from the app rather than logging into Twitter as well. So a few things we need to do before doing a quick test of this. You need internet access, so you may have that on your phones already. There is Wi-Fi in the building with the network King's House Wi-Fi, password KHGuest9, and this is also written on the agenda, at the bottom of the agenda. So if we want to just do a quick test of this, once people try and log on, so you need to go to www.slido.com once you've got connected onto the Wi-Fi. If you're on a phone, it should look a little something like the image on the left, which is a bit faded, but it's a very simple web page with an area to put an access code in. And if you're viewing on a desktop PC, it'll be a bit larger, but there's still just a simple area to put a code in. So the event code and hashtag for Twitter is QIConf. So if you put QIConf in there, I'll give you a few moments. So there'll be people going around helping if you need any assistance. Once you're getting logged in, you should see something a little bit like this. You can see in the top left-hand corner of the screen, there's a menu icon. So if you click on that to drop it down, you'll see there's an option for live, which is basically the screen you need to be on to access all the current polls, the slides, and ask any questions you'd like to ask. The second option is live stream. So not that many people in the room would want to be watching the live stream as well as watching it live. There's a slight delay on it, but if you're watching at home, you could have the live stream on your computer or on your phone and then access Slido on your desktop. The fourth option down is My Profile. So if you go onto that, you can add in your Twitter login and password, and that will enable you via the third option in the menu, Social, to then just send your tweets using the hashtag, and that'll register on Twitter. You'll see as well, so when you're on the live tab, you have three options along the top. So the questions tab is just ask us questions throughout the day. There'll be special times during the panel discussions, so following the project presentations, you might like to ask questions to presenters. Polls will activate when the time comes for those, and we'll do a quick test in a minute. And then slides is the tab where you can just open up a PDF of all the slides we'll be showing today if you want to review anything in more detail. So we'd just like to do a quick test to see if people have got connected to this. So if you want to get to Slido, it should automatically open up at the polls tab. Remember, the code to use is QIConf if you're not logged in yet. Okay, Just going to activate the poll in a second. Of course, if we're not showing it on the screen yet, but if you're on the app, you'll be able to see that we're asking the question, how did you get to the conference today? So was it by car? Was it by train? Was it by bus? Did you walk? Did you cycle? Or are you joining on the live stream? So if you put your answer in and send, we should be seeing this on the screen in a minute. We did test this. So at the moment, 76% of people travel by car. I got the train from St Pancras early this morning. Zero by bus. 2 cycled. I know one of those might have been James, I'm not sure. Yeah. Well, bear with a second. So remember, the first tab on Slido is questions. So as I said, during the panel discussion and during the presentations, if you've got any questions, just send them in and we'll make sure to raise them with the panel. Okay. I think we're just going to move on. Can you activate the next poll? Yeah. Just one more test, because we just want to use this quickly as well. So you'll see on polls on the app as well, there's something that allows you to generate a word cloud. So we're asking you the question, what did you have for breakfast? You can type in a couple of words and it generates a word cloud on the screens, and the most commonly typed in word will be the largest one on the screen. So we're going to do that a bit later on when we're sort of running through some of the items. But I think we've got a few technical issues, but we'll have a look at those in the break, and this will be working later on. So I'd just like to hand over to Nin, who's going to introduce our first project presentation.
Thanks, Tim. Hi, good morning, everyone. My name is Nin, and I'm the QI lead for Bedfordshire. It's lovely to see you all here this morning. So coming up, we have 2 project stories presenting to us this morning to share the improvement work so far. If you have any questions throughout the project stories, do send your questions through Slido, as Tim mentioned earlier, and that can be picked up and we can address it at the end of the project presentation. So the first project presentation we have here, I would like to welcome the team, Emma Ellis, Emma Townsend, and Sophie Venters to the stage. So the project team is from the neuropsychological part of the memory assessment service, and they've been working on this QI project, and I'll welcome them to share the improvement work with us.
Thank you. Yes, we're going to talk about our project, which is focusing on reducing time to complete the neuropsych part of memory assessment. Thank you. Okay, so there are 9 of us in the project team. We're all here, actually. I think except one of us today. So we're made up of assistant psychologists, trainee psychologists, and clinical psychologists. And we're all involved in providing neuropsych assessment as part of MASS, and that's in Luton and Beds. A little bit of background. The 4 MASS clinics are all undergoing QI projects to reduce the time through the pathway. We decided to do a cross-clinic project, so that's just for the psychology part of it, because we felt it'd be really helpful to try out different things in the different projects and then share the learning across the 4 teams. Neuropsych is offered to some, not all, of people who go through MASS, and that's linked to NICE guidelines. And we felt this was important because we're aware of some of the challenges in doing this in a timely manner, so we felt it was really important to do that. I'm going to hand over to Emma. Thank you.
So this is our driver diagram. We're not obviously going to go through all of this, but you can clearly see our aim is to reduce time from referral for neuropsych assessment to completion of report and feedback to MDT by 6 weeks by April 2017. You can't quite see our lines on these, but they are all joined up nicely. So one of the first things we did is did some flow charting. So this is relevant to all 4 MAS teams and enabled us to pick out which part of the process we were getting stuck with and where the bottlenecks were. So the bottlenecks did vary for different teams. It also enabled us to check that we were collecting all the right data points. So we've put all the data points in red, and the numbers after those correspond to our spreadsheets.
Okay. So this table just shows a list of the different PDSAs that we've done across all of the different teams. So some of them we implemented in all teams. Some were specific to a team based on the procedures and processes that we'd identified were most important for them.
So this is an example of one of our successful PDSAs. So me and the other assistant psychologists were finding that we always had lists of outstanding clients whose reports we needed to write. So people that we'd already seen but hadn't written their report yet. This caused a certain amount of stress, and also when the time came for us to write the report, they weren't necessarily so fresh in our mind. And then when the supervisor asked us questions, we couldn't remember necessarily. So the change idea was to allocate blocks of time to score assessments and write up reports. So this would hopefully provide focus and lead to reports being written more promptly. So cycle one involved one assistant allocating slots and scoring and writing out reports for 1 week for all assessments seen in that week, and then feeding back to the wider psychology team. So the feedback was the process of writing the report was quicker and noticeably easier as the information was clearer in my mind. The next cycle involved all assistants trialing this method and feeding back to the team. There were some difficulties because of the backlogs of reports and also competing priorities. However, the feedback was that the draft reports were written more effectively, efficiently, and the structure helped to manage the workload and clear the backlog. Further to this, more details could be provided, and the notes made during the assessment were more meaningful. And then cycle 3 involves scaling up to all assistants utilising this method, and we're still utilising this method. So this next slide is our graphs, but again, you can't see that very well. But the eye charts show that time from assessment completed to draft report reduced by 78% in Bedford, 87% in Luton, 73% in South Beds, and Mid Beds we didn't have access to the historical baseline data, so we used a run chart for this, and that reduced by 63%.
So this chart is just showing that we've investigated the outliers. This is from the time from the assessment to the draft report in Bedford, and as you can see, there's 2 outliers. So those were where we didn't receive enough information to complete sort of the draft report after we'd completed the assessment. This is another PDSA that we've done. In Bedford specifically, we found that we had sort of a bottleneck of clients who were waiting for their initial assessment, well, their neuropsych assessment, because we were waiting for the initial information. So what we decided to do was to get all information at the point of referral. So at the MDT, we would photocopy all of the initial assessment information from the referring clinician, so that we'd have that to discuss with our supervisor and then plan the assessment. And as you can see, this was a successful PDSA, so we reduced the time between the referral received by psychology and the assessment completed by 65%. And another piece of work that we've been involved in, so 2 of our trainee clinical psychologists, Laura and Wendy, have been developing a service user experience questionnaire. We really wanted to involve service users more in this project. And so we're gathering information from them about how we could better sort of improve our neuropsych assessment pathway, in their opinion. So what we've done is develop a questionnaire which was trialled with some clients and has been further modified, and now we're implementing this across all teams. And we're still collecting data, but we're hoping that this will help to inform further change ideas and PDSAs. We identified some challenges in terms of when was best to give the questionnaire to clients, especially due to the fact we're working in a memory assessment service. So thinking about ethical considerations of clients completing questionnaires in front of us. So we've given clients the option that they can complete the questionnaires at home and then send them back to us if they would like to. So these are some of the outcome measures that we've got so far. So these are from the referral received by psychology to the final report being completed. So as you can see, in Bedford, the time is reduced by 40%, in Luton by 43%, in the South Beds team by 42%, and Mid Beds, we're using a run chart here due to the having less data, but that's reduced by 28%. So in terms of our aim to reduce the time between the referral to psychology and the final report being completed, you can see that in Bedford and in South Beds, we've met that aim. So in Bedford, clients typically wait about 39 days, which is less than the 42 days, which is our aim. And again, in South Beds, clients typically waiting 42 days.
Okay, so finally, just our learning. So we learned about the importance of creating operational definitions across the teams. We realized there were slight differences in the data that we were collecting. So just defining these definitions meant that we were collecting comparable data. Flow charting helped us to define the process, to identify what data to collect, and notice variation in the teams. So, for example, that bottleneck in Bedford team was between referral to psychology and assessment booked, and then there were different bottlenecks in other teams. The challenge of a project across geography, across teams in terms of geography. So we had to make use of Skype meetings with Emma emailing around agendas beforehand, and also recognizing difference between teams and changes within the team. So staff changes in processes. So what's next? We noticed another bottleneck between when we complete the draft report and reports finalised by supervisor. So we're aiming to run a PDSA to finalise the reports quicker. This is going to be a challenge for our clinical psychologists with competing demands. So we're considering what balancing measures we can use to look at the impact of these changes, given that all of our clinical psychologists work within the wider CMHT or across other services. And then our final thing that we're going to try and do is create an X-bar-S chart to combine the data across all teams. The end.
Thank you for sharing your improvement work with us. It's brilliant, and I think it's a good example that how you've demonstrated that you've used QI methodology to help you to guide your improvement work. So amazing. I'm just going to have a look at my phone to see if there's any questions that's come through. So I have a questions here. Could you share with us what are some of the challenges that you face during your time working on this project, and how did you overcome those barriers?
So I suppose one of the main barriers is because we work across different teams, so finding the time to meet, like Emma said, we've been doing Skype meetings and over WebEx and things like that, so trying to connect across all of the teams when there are competing priorities.
Another challenge, I think, is changes within the memory clinics. So the wider memory clinics are also doing QI projects, so their processes are changing, so we are changing within that as well. So that's kind of been difficult, but I think we've just kept focused on ours, working within the wider team.
I've got another question here. And it says, what was the missing information which caused the delay in the memory assessment service reports being written up for the two outliers?
So one of the missing data was for information about activities of daily living for that client. So we were able to sort of complete part of the draft report, but we were still waiting on that information. And the other one was waiting for information sort of from the initial report. So we were waiting for a clinician to write that report.
Thank you. Another question here says, do you think you would have achieved what you have right now without using the QI methodology?
Good question. Possibly not. I think it's just helped us approach it in a really kind of structured and thought out way, and to compare kind of different ways of managing things across the 4 teams, and then to roll out those things that have been successful. Do you want to add anything? Thanks.
And I guess the final one that ties up the whole project, and it's the question and answering session, is how does this work make you all feel?
I think we're really pleased with the progress. I think in psychology we are kind of always thinking about how we can improve things, but we wouldn't necessarily have done, you know, all the charts and things like that that really show what's been improving. And it's been helpful actually organising this project, this presentation, because it's kind of brought everything together, so we realised what we've kind of done. Whereas I think maybe before we knew that we'd done something, but not quite sure.
Thank you very much. If we can have a round of applause for the team again. Thank you very much. Next, I would like to welcome my colleague, Ishrad, who's the QI lead for Luton, and she's going to introduce the second story we have today.
Hi, so now we've got another QI project that's coming on. This one has made some really great use of the methodology. It's seen some really good results, and it's actually seen them very, very quickly as well. And it's actually in a corporate area this time, so it's really interesting. We've got the Rio project team that are on the table over there, so it's nice to see them in the room too. And I'm going to introduce Sheila O'Connell and Dermot Flynn to talk a little bit more about the project. Similarly, if anyone's got any questions, keep sending them in and we'll collate them to feedback.
Ooh. Hi, good morning. Can you all hear me? Yeah. I'm Sheila O'Connell and I look after the Rio team up in Luton and Bedfordshire, and have a phenomenal team of trainers. What we found when we started up here was it was a bit sporadic. How do we get people into training? How do we do it quickly? And that really gave us the impetus to take on a QI project. Interestingly, the QI project team is made up of a variety of people from different disciplines. So we've got a clinical member of staff, we've got, we had a trainer as well, and we've got administrators, all from the CMHTs, because it's important we know how we impact on them. Damn it, that's just gone off. So the rationale for our project was to streamline getting people into training so that we can get them into the wards, onto the CMHTs as quickly as possible, able to use Rio in an effective and safe way. We wanted to simplify it. What we were having was the trainers would come to me and say, oh, do you know, we've got a huge inbox of emails, and it was, you could have as many as 10 backwards and forwards email conversations just to get one booking, and we had to find a way to simplify that, not just for us, but for everyone else as well. So we also, and one of the major things was, how do I get the trainers freed up a little bit more to actually concentrate on courses and things like that. So that was where we were coming from in what we were trying to do. I don't know who does the clicker bit.
Okay.
Oh, there we go.
All right. These are our driver diagrams. I don't know if you guys will be able to see them very well, but our primary aim, as Sheila mentioned, was to try and make available an online booking system that all staff could book their RIO training on, thus reducing the impact on the trainers and allowing them to have more time to provide training and provide support to the CMHT staff who would just, remember, we just started rolling out RIO within the CMHTs and all of the services here in Luton and Bedfordshire. It's only about 18 months ago. So, and our aim was really to try and reduce to increase the amount of online booking by about 20% by the end of this month, March 2017. And I'd say the drivers for that was to try and reduce the impact on the RIO trainers and make courses available in an easy way that everyone was pretty used of, because most of the staff are used of accessing OLM and being able to book training through that. So that was our sort of drivers for that. Okay, you might have to, or do you want to do the clicker? Right, so what we did in our sort of development thing is initially we looked at developing a form with a standard set of data, because what we were getting is a lot of emails and there was different requests. It wasn't very clear. Sometimes you'd have medical staff trying to book onto the administration training sessions for the RIO, things like that, and people didn't really have a clear idea of what was going on. So what we did is develop the booking form. We introduced it so that all the training requests come in, they had to fill in this form, and it gave us all the basic data set, what training they required, where they would want it, because there are different sites across the county that they can go to be trained on. Once we started collecting that data and getting the training, I remember these were just sort of coming in through emails, so the forms were being emailed, so we were still having to analyze them and still having to work on the emails at this point. But we started collecting, interpreting the data, figuring out what we could do to try and make things easier. Do you want to go to the next one? And what we found out as well is we had initially started trying to review the data on a monthly basis, but we found that that didn't give us enough data points and enough information to start to interpret. So we had to alter our data review methodology and to do it weekly. Then the next thing, once we had all our data, we'd agreed what we wanted in our form, what we wanted this staff to be able to see on the OLM site. We spoke, or Sheila contacted the OLM, we liaised with them and got it the form put on OLM. So people themselves can now just go on, or managers can log on to OLM and book the staff's training. And that went live, I think, mid-December. We put that onto OLM for staff to be starting able to book into the January training sessions. So yeah, this gone live in December. So now we're in this process of just analysing the data to see where and what improvements it has had and the impact it has had on our RIO trainers' time. If you want to go through some of the data. I mean, you won't necessarily see some of these graphs very easily from your point of view, but effectively this is the number of incoming emails the staff were having to deal with on a sort of a daily basis, or weekly basis, sorry, from September, October and November, and then the outgoing emails. And if you can see sort of halfway through our graph there, around about that December time, you can see a massive reduction in the emails both coming in and going out. And the total training requests that are coming in through the email system now, and just people not booking through OLM, has significantly reduced. And we've actually met our target of 20%. We would say at the moment, even though we're not still fully at the end of the period, the data collection period. Our learning. We figured out, obviously, with, as Sheila is saying, the previous methodology for booking training was very time intensive and very, a lot of emails coming in, clarification emails coming from managers or coming from Sheila to the managers. Because as you say, often Sheila would get emails in saying I need 4 people booked on training, but it wouldn't tell you what discipline, what training they needed, whether it was their administration training or medical training or sort of care coordinators level training. So there was a lot of back and forth emails clarifying things before things could be booked. The booking, putting the booking system on OLM means that the managers now can go in and they can take the specific training that their client or their staff member needs. So there's no emails going back and forth. They're have massively reduced. And the multidisciplinary team project, because of using the, as Sheila said, we had clinical side, we had the administration, we had the Rio team, we were able to draw all that together to see where the difficulties sort of come up from the clinical point of view in trying to get staff trained, the administration point of view and how to manage it, and then obviously for Sheila and then in booking the staff into the appropriate trainings and having the trainers available to provide enough training sessions. And that we hope obviously that we can go forward with this and continue to develop this process, because I know there are some other challenges that you're going to go through now.
So the first challenge that we really came across was the fact that if we did it on a monthly basis, we only had sort of 1 or 2 data points. So we decided very quickly that we needed to change that to do it on a weekly basis. And we did that quite quickly and started to see trends really sort of starting to show. Next.
I'm reading them down here.
We really wanted staff to book themselves on because it's faster. We also had the thought that, you know, managers know when they've got new starters coming. So why can't they book their new starter onto a Rio training course within their first week of service within ELFT, as opposed to maybe 2-3 weeks in, as it had been from the back and forth of emails. What we're now finding is that people are booking in. The significant reduction of traffic through the email is amazing. The trainers have said to me, oh, this has really worked. And I don't think they expected it to be as positive initially as it has been. And so quickly. It's really encouraging to see it being done quickly. As part of encouraging staff to get their new starters onto courses, I now write to every manager in Luton and Beds on a Monday who has a new starter that week, asking them to get them booked. As soon as that email comes in, it gets done and we get an email out to all the managers, and we're seeing them reacting as well. We'd obviously like to see more people trying to get onto it, but there are challenges, and one of them is that sometimes staff aren't on ESR as quickly as we would like them to be, so that they can then be taken by the manager to be booked on. Agency and locum staff can be a problem because they're external staff in the main, and we have to go through different channels to get them booked, and that's something that we want to work on as a result of this project, because we can see that needs a little bit more attention. And we want to get our training feedback online, and we've just started to do that. We're using SurveyMonkey, but we haven't yet done any analysis of it. So at the end of a training course, I mean, I keep getting comments from people saying, oh, your trainers are wonderful and we really rely on them, and when can they come back again? And that's really heartening, but we want to improve on what we're giving them, on what we're offering. So we want to expand our courses. For example, at the current time, we're rolling out the ECPA training. As from April, we will have sessions in every month for new starters to do that as well. So they're not going to miss out on this groundbreaking new way of working. And so the team now that we're all permanent, we're looking at ways, how can we help you? And I guess that's my plea to you. Tell me what you want my team to give you, and we will do everything we can to do that for you. Thank you.
Okay, thank you both. That's so much progress in just really what is a really short space of time. So well done, it's absolutely brilliant work. Because we're running a little bit short on time, we're going to have just one question that's come through. You talked a lot about the success of the project team and how you've got everyone to come together and meet regularly. I think that's something that a lot of project teams are really interested in. One of the questions that have come through is, how did the use of Skype meetings make things easier for you?
I think in one word or two words, it didn't, because we were all based in the same room, in the same building, so we didn't have to use Skype, but we would have if that had been an option. So I can see how it would be useful.
Okay, there you go. It was a genuine question that came through, so interesting. So I'll just pass on to Amar now to introduce the next speaker.
Thanks very much, Ishrat. What a wonderful way to start the morning with two stories of teams who've used QI to improve the way they function and respond to the people using the service. So fantastic way to begin the morning. It's my great privilege now to introduce the first keynote of the morning. We're really delighted to have with us Professor Chris Hamm, who's the Chief Executive at the King's Fund. The King's Fund is an independent charity that works to improve health and care in England, and it does that through research and policy analysis and bringing people together at events. Chris has a long history of working through research and through analysis to help improve health and understand healthcare reform. He's worked as Director of Strategy at the Department of Health for many years. He's advised the World Health Organization, many governments around the world as well. So he's here to help us think a little bit about how improvement can help us within a world of constant change and reform. Chris.
Well, good morning. Thank you for inviting me. Can you hear me at the back of the room? Is that okay? I think I'm going to drop this any second too. Can you help me on that one? Thanks. Well, first of all, I'm delighted to be here. The King's Fund had a really close and positive relationship with Amar and colleagues in ELFT over the last 2 or 3 years. We're using some of your experience for a new report we'll be publishing soon on how to bring about improvements in quality within mental health services, and you've been very generous in supporting us in that work. What I'd like to do today is just take about 20 minutes or so to reflect on what I've heard you speaking about so far this morning. Very good to be in on the stories and the examples that reflect the work you're doing, and then try and put that in the broader picture around what's happening across the NHS in England and the challenges, but also perhaps some of the solutions as we move forward. And the theme, as you can see, is how can we reform and improve the NHS, deliver better care for patients from within, drawing on all the expertise in this room and many rooms like this, as trusts, as commissioners, as others come together. Here are the 3 big challenges that the NHS as a whole confronts at the moment. How can we sustain our existing services and standards when there is so much pressure from rising demand, which we've heard a lot about during the course of this winter? But not only that, how can we do even better, develop new and different models of care, better suited to a growing and aging population, and the challenge particularly of multi-morbidity within that population? And then how do we do both of the above? Not by driving the NHS through targets and regulation, these external pressures, but building the change very much from within. So here's the set of issues that we see around sustaining existing services. Of course, number one is keeping a relentless focus on quality of care and on patient safety. Maintaining good performance on some of the key targets. I'm thinking of waiting times, but other targets around quality as well. Workforce challenges are a big issue everywhere. We can't recruit and retain enough clinical staff and sometimes enough managerial staff to support them. And financial pressures are everywhere you look, especially in acute trusts, but in other parts of the service too. So real issues that are growing in importance. And it looks like in the budget tomorrow, the government will decide not to put more money into the NHS. Perhaps there'll be a bit more for social care. So these pressures on finance and performance will be with us for some time. Then the second challenge, not just doing that, but developing new and better models of care. The 5-year forward view is the national strategy for doing that. Simon Stevens and the other national leaders have been very closely involved in its development. And this is about priority for prevention, not just treatment, focusing on population health and well-being. It's about the vanguards, the new care models, which are all about integrating care and joining up physical and mental health, primary and secondary care, health and social care. We've been closely involved at the King's Fund in some of those models. We had a meeting yesterday at the fund with the acute care collaboration vanguards. And I think very encouraging, positive work in many parts of England to show what the future might look like. And it's then about embracing new technologies, digital technologies, Skype, where it works. Heard your story about that. But many other ways in which we can make life easier for staff and above all for patients and the people we're trying to serve. But what I want to talk about in a bit more detail is this challenge of reforming the NHS from within, something that I've felt passionately about for about 20 years now and feel even more so looking at how successive governments have relied too much on these external pressures and not enough on drawing on the expertise of the 1.3 million people who work in the NHS and also, of course, the many millions more who are served by the NHS. That is the challenge. It's the challenge that we can see being met in high-performing healthcare organisations and systems in England, and I would count East London Foundation Trust as one of those, and in other systems around the country, around the world. I wrote about these issues in this paper we published a couple of years ago, really to bring all of this learning together. How can we move beyond those top-down targets and standards that successive governments have relied on, trying to prod and poke the NHS? How do we move beyond an over-reliance on inspection and regulation checking that we're doing the right things? And how do we move beyond too much belief that market forces, choice and competition will succeed where these other instruments have had limited impact? And the argument very simply is, yes, we probably do need a few targets and we do need some regulation, but we've placed too much reliance on them compared with the other approaches. And the other approaches we can see, as I say, around the world. So the one example here, these are the logos of some of the organizations that exemplify what I'm talking about, because what I'm talking about reflects the reality in some of the best organizations that have embraced this approach. So Salford Royal under Sir David Dalton over almost a decade now has been pursuing this path to improvement. The Jönköping County Council in Sweden is another great example with a partnership with IHI to support its work. A long way away, I've been to see this and visit it myself, the Canterbury Health Board on South Island, New Zealand, another inspiring example where the leadership have worked with the staff to bring about changes in care. And then two from the States, Intermountain Healthcare in Utah and Virginia Mason Medical Center in Seattle. All adopting slightly different approaches. There's no recipe here. You have to find what works for you in your context, but all exemplifying a quality improvement strategy, drawing on the strengths of the people delivering care. And this isn't just theoretical knowledge. I just want to emphasize, I've been to and visited and seen and worked with all of these organizations myself. So it's the evidence of my own eyes I want to share with you as to why what you're doing and what I've heard about this morning is absolutely the right approach. Here are the simple lessons, and you might think, given the context in which we're discussing and what the NHS has given priority to, this is rather whistling in the wind. We don't do these things very well, but it doesn't stop me reiterating why we need to do them much better in future. It's having a degree of organizational stability so that we're not rearranging the deck chairs, but we can work with what we've got. Leadership continuity. Having leadership teams that have been in place for long enough to know their organizations, know their services, and know their populations. It's about having an agreed shared vision, which is about quality and safety, always at the heart, quality and safety of patient care. It's about having goals for improvement that you can specify and quantify, and then measure your progress to implementing those goals. And it's about having leadership at all levels, supported by training in quality improvement. And yeah, it's not a mystery, this. All of these elements are in place in all of the organizations that I've referred to. But we need much more. And here are the other ingredients. I won't go through all of these because I suspect many of them will be familiar to you, but I do just want to pull out a few. And the first two, of course, are critically important. It's about understanding how staff and patients work together, how patients experience services, and seeking their feedback so we can learn from what's working, and equally we can improve what isn't working. It's about leadership at all levels, leaders who engage staff, who value staff, who recognize that many of the solutions to the challenges we've got lie within, among the people delivering care, the 1.3 million people. And leaders who are personally and visibly committed, deeply involved in the work, leading by example, not just saying we need to be a high-performing organization committed to improvement, but actually walking the talk and demonstrating this is what really matters to them, as well as to staff and to patients. My colleague, Michael West, who will be known perhaps to some of you, a psychologist by training who's done a lot of work on leadership and management, has been writing about these issues for us in these reports and others too. So when we talk about leadership, we don't just mean the board or the executive team at the very top of organizations. Leadership, if it's going to be effective, needs to be collective and needs to be shared and needs to be distributed. The best organizations in the world have leaders at every level. The frontline teams delivering the care, the directorates and divisions through which those services are brought together, and then of course at the organizational level too. And that doesn't happen by accident, it happens by design, by intention, by building the leadership, clinical, managerial, and indeed I would add patient leadership to deliver on the quality goals and the objectives we're all trying to work towards. I borrowed this from one of the organizations I mentioned, the Virginia Mason Medical Center, which is a great example in Seattle. Been working at these issues for some time. They set themselves the challenge of expressing their strategy on a single page. And this is the single page. And it's a challenge I put to every NHS organization I work with. Can you express your strategy in a diagram like this that's comprehensible to everybody in the organization and to the people you're serving? Two things to highlight, as you can see on here. The vision at the top, to be the quality leader and transform healthcare. A stretching vision, an inspiring vision, but about quality and safety being at the heart of all of that. There's lots of other stuff there, as you can see, but at the bottom, underpinned by the Virginia Mason production system. And some of you may know that over a period of years, Gary Kaplan, the President and CEO of Virginia Mason, with staff at all levels and leaders at all levels, they've adopted their quality improvement methodology. They learnt it from Toyota. They went there, they studied, led by the president and the CEO, and many other staff followed in their footsteps. They brought it back to Seattle, they adapted it as their version of the Toyota production system, and they called it the Virginia Mason production system. And the point to make here is every organization needs to have a method, an approach to quality improvement. It doesn't really matter what the method is, as long as you've got one and you stick to it. But critically important is you have to invest in the training of the staff who at the end of the day will be the ones using that method and bringing about improvements in care. To use a different example, I showed you Intermountain Healthcare. Brent James is the Chief Quality Officer there. He's been in that post for about 30 years now, and a great example of a quality improving organization led by clinicians right through with support from great managers. They have their own improvement methodology, and they've invested in something called the Advanced Training Program. It's a training program, not just a leadership development program in Intermountain, where they train literally thousands of staff over the years in the methods that they believe will help them and have helped them bring about those improvements in safety and quality. And there's a big element in that of mathematics and statistics to give people the tools to do the job, to give them the confidence working with their teams and their clinical colleagues. The point I'm trying to make here is you need the leadership, but you need the tools as well. And that comes through training and support, led from the very top, but then distributed right through every organization. And I think I'm telling you what basically you already know, because I've heard the stories already this morning, but you might be doing it and it might be something that comes naturally. I have to say that it doesn't come naturally across the NHS, even though we have some other great examples. It's work very much in progress. So finally then, here's the big leadership challenge. The organizations that I admire, that I've referred to, are ones in which the top leaders do make a sustained and deep personal commitment. They walk the talk. It really matters to them personally. For us, we need exactly the same, and leaders who are willing to devolve power. One of my other favorite examples from closer to home is the Western Sussex Foundation Trust, recognized by the CQC to be outstanding in its rating last year. Marianne Griffiths, George Finley, Chief Exec, Medical Director, respectively. I went to see them and visit what they're doing back in the summer. And they said the hardest lesson for them as organizational leaders was not to feel they had to do all of this work personally. Marianne talks about not putting the cape on, like Batman or Batwoman. When the going gets difficult, that's always the risk. And they resist that risk, and they say, if we've got challenges, we're devolving responsibility and we're supporting the frontline teams and their managers to address those challenges. So leaders have to change. They have to, as I say, lead by example. They have to trust. They have to take some risks. They have to devolve. That's what leadership at all levels really, really means. And this partnership between experienced managers and clinical leaders lies at the heart of all of this. Quite rightly, people like Bruce Keogh and Aradazi have talked about clinical leadership, but clinical leadership won't work without experienced managers working in partnership with clinical leaders. That's exactly what you see in the best organizations in the world. The two together are much more powerful than each separately. And this takes time. To borrow that cycling phrase, it's about the aggregation of marginal gains. Lots of small changes, which cumulatively over time will enable you to make a transformation from good to great, from great to outstanding. And that's an important lesson. The last thing I want to say is about, yes, we need to do all of these things in every NHS trust around the country, but in the times we find ourselves, going back to the challenges of sustainability and transformation, we need to do this collaboratively across systems of care in a city, in a county, in a geography, however you define that. And I guess that's what the sustainability and transformation plans are now trying to do in England, with more or less success, depending on where you look. So the work I've heard you describing today, that I know you've done from previous work we've done with you, that needs to be spread and shared as widely as we can, because systems need to work more effectively. And that requires not just organizational leaders, it needs system leaders who can work across organizational boundaries and spread the benefits more widely. We have to reframe the debate. This is something I feel really passionately about. Debate about value in the NHS. How do we deliver more with the resources and the budgets and the staff we have? Fundamentally, it's about changing and improving clinical care to patients. Of course, we also need to look at management costs and back office functions and how we use our buildings and the estate. But if we only focus on those things and we don't look at the experience of patients and how clinical care gets delivered, we're missing the biggest opportunity of all. And what we set out here in one of our other reports is the opportunities that we see in every part of the NHS to do that. And improving clinical practice can only be done by the staff delivering the care with support from leadership teams, because the NHS will only rise to the challenges I've described if we're able to engage and support staff in the challenges that you're involved in and that we see happening elsewhere. So I think I'm taking a long time to say carry on with the work you're doing, because the work you're doing seems to me to exemplify many of the principles I've been outlining, and I wish you every success as you take that forward. Thank you.
Thank you very much, Chris. I really enjoyed listening to that, full of nuggets of leadership, support, and guidance. We've had some really interesting questions come through, so I was wondering if I could pose two to you that particularly got attention from the crowd here. The first one is, what, if any, is the difference between quality improvement in mental health settings, which is the area of work where most of the people here in Bedfordshire and Luton are engaged in, compared to quality improvement in other healthcare settings?
So my view is there probably isn't much difference. That there are some general principles around quality improvement which you'll be familiar with, and I'm sure you'll be hearing more about that later on today. Go back to what I mentioned with the Virginia Mason production system. That was stolen, if you like, adapted from Toyota. And of course, making cars is very different from treating people who've got a variety of healthcare needs, but it was adapted to suit the needs of one healthcare organization. And we've got some good quality improvement methods and experiences in acute hospitals, increasingly in community services and in your own work. So I don't believe there is any fundamental difference. It's about having a method and then following through in the way I've been discussing.
Thank you. And you've given us a lot of lessons and tips about what it takes to lead in this time of challenge. One question that came through is an interesting one. What advice would you give to those of us working in frontline care delivery to be able to support and nurture this change in culture?
So I think this is the key, isn't it? There's no point in leadership teams at an organizational level saying this is important if there isn't the commitment and the buy-in among the frontline clinical teams. Part of it, I think, is recognizing the challenge of the intensity of the workload and the workload pressures that everybody is under, and the need to create some headroom and some space to get off that treadmill of treating the patient in front of you or thinking about the many patients on the waiting list to see you, because we're not going to do the quality improvement work if we just keep on pedaling harder on that treadmill. We've got to find a way of creating time and space. And I always go back here in relation to your question, Amar, to the work of Jill Mabon, who's a professor of nursing studies at King's College. And she did a study some years ago now of why some teams are more successful at meeting patient needs than others and delivering better results. And the key finding from that was it came down to team leadership. And typically it was having a skilled and experienced nurse leader of the team she looked at, who were able to motivate and support the other team members to create the time, to create the opportunities for reflection on professional practice, to create the time for training in quality improvement, and to lead the team in doing the day job, but improving on how they were doing the day job and freeing up the time and the people to reflect in that way.
Wonderful. Thank you very much. Could you please join me in thanking Professor Hamm? So I'm going to hand you over now, as it shows on screen, to James, Fareed, and Michelle.
Hello, good morning everyone. I'm Fareed Jabbar, Clinical Director in Luton. Over the next 15 minutes or so, Michelle, James and I will talk about the challenges and progress of QI in Luton and Bedfordshire and how it feels in general. Without saying much more, I'll hand you over to James Innes.
Thanks, Fareed. So I get to do the fun bit, which is talking about the progress and what progress we've made. So we always love to start with driver diagrams, don't we? We love driver diagrams in QI, and this is the driver diagram for our QI program. So all the way there on the left-hand side, you'll see what we're aiming to do, kind of links nicely with what Chris was talking about earlier on, which is to deliver the highest quality mental health and community care, full stop. And over in the right, these big blue boxes, they're the big bits that we think it's important to work on. This is our theory. So we think there's something about encouraging and inspiring people. There's something about building skills around QI. There's something about embedding this into daily work. And then finally, there's the QI projects. So let's start with engaging and inspiring. And actually the work started a year ago, pretty much today, at the first QI conference for Beds and Luton. And that's where we started those initial conversations, I guess, about what QI was and what it meant to us as we started the year ahead. And shortly after that, we tried to speak to as many people as possible through road shows, through away days, just anything we could really. And we managed to engage around about 100 people in the first couple of months, just to start those conversations going. And that obviously jumps on to other stuff that we're doing, for example, our newsletters, the QI microsite and stuff like that as well. So what about building skills? Chris talked quite clearly, didn't he, about building capability, and it's really, really important to do that. So I guess let's start off with Wave 5, Improvement Science and Action. So that's our 6-month course, and which is designed to build deep skills, basically, for people who are doing it. And that started back in September at the Carnival of Arts. Can I have a show of hands? Who was on Wave 5 in the room here? So there's quite a few of us here, yeah? And Wave 5 will be graduating this day next week on Tuesday, so that'd be fantastic. That was around about 100 people who went on that course. We also now have regular Pocket QI sessions operating in both directorates. They are running pretty well, actually, and they are designed to be a shorter course to give more access to people, so 2 half-day modules. We have Introduction to QI for service users and carers now operating regularly in Luton and Bedfordshire. And we've also built capability with a layer of improvement coaches. So we have 6 coaches, and we're at the moment recruiting to a next cohort as well. But what I love doing as well is it's not just about working with staff here, but it's also working upstream. So I'm really proud to say that all of the University of Bedfordshire student nurses are now doing QI. We're teaching them as part of their course, but they're also coming to East London and doing QI projects. So I think it's really important to upskill our future leaders. And we've also got a small number at the moment of psychology trainees as well, who are also doing QI projects as well. So that takes us to around about 200 people that we've built capability in just this last year. And then I guess the next bit, which is the toughest bit sometimes, is you built skills and you built will, but without actually making this easy to do as part of day-to-day work, you're in big trouble. So we've been quite busy trying to build some starter structures to help us do this. So I guess it starts, we've got some QI sponsors who are operating in both directorates. We've got our QI coaches that I mentioned. We've got Nin and Ishrat, our 2 QI leads as well. And around them we have QI forums now operating in both directorates, really there to sort of look at how projects are doing, to help support projects that are already going on as well. We have QI Life, which really has come of age in the last year, and all QI projects now are using that, sort of full stop. And some of those results you saw earlier on, those graphs were all created using QI Life. And finally, there's the quality performance and dashboards, which have always been there, but we've made sure we've adapted them for people in Beds and Luton, and particularly if there are things that you needed, we've got those there as well. And let's finish off just thinking about the projects. So the number of projects is always going to go up and to go down. That's the way things work. But what I think is more important than the number is just some of the flavors of some of the projects that come out. And this can only happen when you've got a bottom-up approach. So look at some of these things like improving access or recruitment or experience, stuff around increasing co-production, responsiveness, and reducing things like aggression and violence and seclusion. I mean, they're all really important things that were created by local staff. And clearly, lots of those projects, I'm so sorry for the poor dots and the no lines and stuff, but all those projects now are creating data, using data. And you only saw 2 here, but there are many, many more who are all working away, which I think is absolutely fantastic within a year. So let's just see a video summary, and I cross my fingers that the IT gods are playing nicely with us. And if not, we'll show it later.
Really helped me to connect with other staff members and help talk to them about people participation in the co-production side of quality improvement.
I would encourage everyone to participate in a QI project and to go on the training if you have a chance, and including some of our carers, service users and commissioners. I think it's invaluable for everybody.
It is allowing us to gain an understanding how we can affect change ourselves rather than have change imposed upon us. And it's allowing us to focus in on what is the right things to change. It's given us the tools and the skills to focus our energies on the appropriate changes to make to improve systems for both ourselves as workers, but also for our service users and their overall experience of care.
Together we have developed a mental health triage tool, which is used by the triage nurse when booking patients in for a brief psychiatric risk assessment in a mental state, leading to a triage code, which leads to better risk management and risk stratification in A&E.
Using this triage tool, we are able to observe our patients much more appropriately while they are waiting for their psych liaison assessment.
100% of the A&E staff have been trained in using this mental health triage tool, and the feedback from the teaching and using the tool has been very positive. Thank you.
Are you ready to break the rules?
Michelle.
Thank you, James. First challenge, the step. Achieved that. That was good. Okay, so how does it feel then? We've already heard about the successes of some of the projects locally, so they should be the sort of party slide in terms of where we are. But I wanted to get some reflection about how the other project teams are feeling. So the first one, for those of you who are 50s, 60s child, may remember the It's a Knockout television programme that used to be on. And they used to be very simple races. It seemed simple. You knew the destination. You could see the line there. But what would put big shoes on you in a clunky outfit and then make you try and go through that process. And suddenly it seemed a little bit more difficult. So you were willing and able, but actually there were these things that were coming in the way just to sort of make it feel a little harder than it needed to be. So that could be Luton and Bedfordshire and Newham and racing against each other in those days. So I think there's something about, for these people, they're willing, the teens, they want to get it done, they're hopeful. We think those projects will get there, absolutely. But it feels a little bit clunky and awkward in terms of the journey. And then there's the projects that perhaps feel a little bit painful, the projects I wish I never put my hand up for. You know, that why did I suggest we would do that? The ones that are locked away in a cupboard, and we'll bring them out and look and talk about them for now if we really have to, and put them back, and it just doesn't feel right. It certainly isn't business as usual. The staff team really, you know, they're just not engaged with it because they don't really understand what we're trying to achieve, perhaps. And I think for these ones, these are really hard because it's such an add-on to what people are doing every day. And it's very easy, I think, to find something else to do instead of looking at that. And that's the problem, I think, because then it's seen as being a bit negative. And I think you could call those PDSA cycles, or you could call them hoops. But how we perceive hoops sometimes is that they're just hard work in terms of how we have to get through and do something. Now, that's not me. Fareed said, is that you? Really? Don't get that at Take That concert. Anyway, so the third group I thought was really about, these are trying, these group projects are really trying, and they're recognising it's hard work. And I think, again, these are the ones that just feel like they're really slow and quite tough in terms of getting some traction. And I think that these ones, I think, will get there as well. You know, I just think it's really hard because life is busy, work is busy. And I think it's really hard to think about those tick box priorities that we're trying to do every day, to step out of that and think about something in a more planned and structured way and taking more time to do that. And I think that this is how we sort of perceive that those are the projects. But please tell me if I've got that wrong. And then finally, this is the willing but we're lost. We haven't got a clue projects. Please help us. So we're in the QI mobile, but we're not really sure of our destination or how we're going to get there. But we are absolutely up for it. But we haven't got the map. We haven't got the sat nav. And again, the support is out there for these projects. So actually, if you've really got that idea and you want to make something happen, do find your coaches and your sponsors and talk to us, because we are there to support getting you out of that. I'm now going to hand you back to Fareed.
Thank you, Michelle. So are we succeeding? I think we already have. I mean, if the slides didn't convince you and all the data, I think you just need to look around and see all the people around and the background of the people here. We've got staff, service users, commissioners, colleagues, etc. So I'm very confident that we will develop. And I don't think we can really fail at the trajectory that we've had, the pace of change, the commitment, the positive sort of projects that we had. I don't think we will fail. Support is available to everybody, really, and everyone should really be part of QI. If you're not part of a project, if you're not doing a project, please be part of a project. Please try and take part. There's plenty of support available through coaches, through the forum, etc. We are committed to making this happen. The whole sort of ethos is around making this work. We will make a difference. Our idea is to provide the highest level of care, and we will do that. Absolutely, I believe the trajectory is there. I think we will get there very soon. That's all I want to say. Thank you.
Thanks. So, you've heard from us, but we want to hear from you now, because we completely acknowledge we've got so much experience in this room. You guys have all been doing this or being involved in this, and we'd really like to get your thoughts. So if you look in your tables, you will find pieces of A3 paper that look something like this. And this is what we call this is actually called a force field analysis. It's one of the tools that we teach when we're doing QI training, and you can use it to apply. You can apply it to anything when you're trying to think through a problem. On the left, we have what we think is helping QI at the moment. So what's been helping QI over the last year in Beds and Luton? On the right, what do we think has been hindering QI? What's been getting in the way? What have been the obstacles? And at the bottom, what could we do to tackle those obstacles? So the idea is we're going to spend around about 10 minutes at tables now, thinking it through as table discussions. I'd be really, really keen, and we are really, really keen to get your thoughts about what you think is helping, what you think is hindering, and any ideas you've got. For those people who are watching virtually as well, we'd like you to think that through as well. And if you use Slido and type in your questions or into the question bar, your thoughts about what's helping and what's hindering, we'll also put your thoughts down on one of these and put it together. So if you'd like to spend around about 10 to 15 minutes, I'll give you a time call. If you start having a chat and start having a good chat about what you think is helping and what you think is hindering, and we'll bring it back together in a minute. Thank you. Just coming up to about 5 minutes left, but make sure you write your thoughts on those pieces of paper. That'd be great. Around about 2 minutes left for the force field analysis. Okay, last minute. Okay. So, could I ask one person just to lift up your A3 piece of paper? And some people are going to come and pick those up from you now. So if we could start picking up those pieces of paper now from each table. And whilst we're doing that, we're really interested to see what you're doing. And what we're going to try to do during the remainder of the session and through the tea break is pull all those key bits of information that you've got put together there and make it into one big force field analysis that we can then present back to you. Because I think it'd be useful then to frame some discussions later on about what you guys have come up with. But there's definitely something about all of your collective wisdom coming together and having a good conversation about that later on. Does that sound good? So I've got one more task for you. Just in the last 5 minutes. We're really interested to hear from you about what matters most. What do you think matters most? What are the biggest priorities you think we should be using QI to solve over the next year? On your tables, you'll notice that you've got post-it notes. We're going to try and limit you just to 3 post-it notes per table and try to limit it rather than big long sentences of paragraphs. Limit it just to 1 or 2 words, but maybe to have a quick chat. And this is not about what you think needs to happen. It's more about what you know needs to happen. Think kind of frontline. Think whatever you think. What are the kind of most important things to you that matter? We'd be really, really keen to do that. And once again, when we come to the end of that, we'll take your post-it notes and we'll try and put them together and show them to you later on. So you've got about 5 minutes just to think about what matters most. What would be the key critical things, the top 3 things that you'd focus on if you had the power? Okay, last few seconds. Okay. So if I could ask you to leave your post-it notes on your tables, and once again, what we're going to do is we'll take those, we'll put them together, we'll figure out what the strongest themes are, and we'll show them to you later on, and we'll try to get you guys to vote on it as well. So that was quite thirsty work, I think. So we've got tea and coffee, which will be out in the rear. One last thing before we go for tea. After the tea break, we're going to have a question and answer panel, okay, with these people up here. But what I was going to ask you to do is, based on what you've heard, maybe if you want to put some questions to the panel, use the Slido function and the question bit and type those questions in now. And then what we'll do is we'll be able to ask those questions later on for the panel. So think about those questions. If you've got any, type them into Slido during the tea break, and we'll try our best to ask those for you later on. So we've got 15 minutes for tea. So I would say that we'll be back for 11:25. And like I said, tea, coffee and snacks are straight out into the rear. Thanks, guys.
I'm sorry I can't be the I'm sorry I can't be at the conference today. I've got a prior engagement, but I think just to I'm sorry I can't be at the conference today. I've got a prior engagement, but I think just to
We'll be commencing our second session in about 5 minutes. 2 minutes, everyone. Can you please take your seats? If everyone can make their way to their seats now, we'll be starting. Right, so to start the second session, we've got a couple of messages from national and international leaders who couldn't be with us here today.
I'm sorry I can't be at the conference today. I've got a prior engagement, but I think just to, if you haven't been congratulated by enough people, it's always good to be congratulated, but well done on the outstanding. Obviously, it's really good to have outstanding, but it's even better to get the next one that's outstanding and make sure you are and continue to be the best in the country. And look forward to working with you and all your colleagues to make sure we ensure that happens and that the residents of Bedfordshire get the best deal they can from their health provider and health in particular. Within the public sector, within whether it be local government or the health service, we're seeing the pressures on our budgets that are huge. I've just we're putting together a budget that looks at a £27 million cut in our budgets on top of the 90 million we made already, so that's about a 40% cut. And we can't do things the same. We can't do things the way we've always done them. And that's the same in the health service. The pressure on the health service is more and more people want services. The treatments, the things that people coming with are more and more complex. They don't just come with one problem, they come with multiple problems. And that's often, it can be physical and mental health combined, and they can sort of feed off each other. So we've got to do things in a different way. We've got to think of innovative ways. And the conference, as I understand it, is looking at ways you can share those different ways of giving people in small teams the power to make some changes that will affect people's lives. The more we can do that, the more we can share those ideas. So we can say, this worked for me. Does it work for your area? No, it doesn't work, but it works slightly differently. Will be really great. And we need to share that across the entire public sector, because unfortunately, looking ahead, I don't see more money within the frontline service. I see less money, and we have to do things innovatively. If we keep on doing the same thing over and over again, we're going to get the same results, but with less money. So I wish you well, and actually do help you come up with those innovative ideas and share them with all of us.
Hello, welcome to Orlando, Florida, where we're now starting the 28th National IHI Quality Forum. We just finished the winter camp for our strategic partners, and colleagues from East London Foundation Trust have joined us here to share their work and ideas, much of which you folks have already been a part of. We've learned today that work at East London is expanding to think about not only health care that we deliver when people come to us for service and in need, but also to think about the quality of life. And as we move the work to Bedfordshire and Luton, it's going to be very important that all of you become part of this quality journey. I enjoyed my site visit recently and really look forward to the fact that we're going to continue to work together to build capacity, capability, and every day start to think about how we can make life better for those we serve. So have a good day. Thanks for joining us, and I look forward to my next visits. Take care.
Hi, it's Derek Feely from the Institute for Healthcare Improvement. It's great to see our staff from Luton and Bedfordshire so actively involved in this quality improvement conference. It seems to me that you're off to a fantastic start. What great progress you're making, and I'm sure what you're going to learn during the course of this quality conference will stand you in good stead to continue to make that progress. And I think what you'll find as you get more deeply involved in quality improvement is this is going to be an opportunity for you to really leverage your skills, to really apply what you're learning to the benefit of patients and families. You'll find an opportunity to generate ideas and to really make a difference, but much still to do. And we look forward to standing right alongside you as you continue on this journey. Well done, and have a great day.
Right, I'm going to pass you to Oz, who's going to lead the next session.
So we did an exercise just before we broke for the tea break, which was your force field analysis. And this is just a quick snapshot of everything that came out from that exercise. But we did a bit of an exercise to read through them and draw out the main themes. And these are some of the themes that you wrote on your charts about what's helping QI, what's hindering QI, and what can be done to tackle what is hindering QI. So I'll just give you a few seconds just to have a read of it, just to see how what you were discussing at your table, how some of those themes also being discussed around the room. So we'll try and draw on some of these themes as well for the discussions that are coming up. I would like to invite our panelists just to take their seats on the stage. Now, while they're making their way on Slido, most of you have been posting questions that we're going to post to these guys at the end of the pre-prepared questions that we have. You might want to read through them and maybe vote on them. So click the like so that we can see the ones that stand out and pose those to them. But also we'll be going around the room with microphones a bit later. So thank you all very much. We won't spend time introducing you because your names, faces, titles, it's all up there. And I'm sure everyone's very familiar with these faces. So we've got a few questions for you that have been prepared. So the first one is for Zalfa. So Zalfa, what are your initial thoughts on what we have heard so far about what's helped QI over the last year? And how do we build on this?
Should I stand up then? Yeah, I'll just take this, yeah. Yes, good afternoon, everybody, and I'm delighted to be here today. Yes, a lot of what's documented there is actually what our table came up with as well, actually, so it really resonates with what we're thinking has been quite helpful in terms of the whole QI thing. Now, and I suppose when I first came to Bedfordshire, and I was fortunate enough to come up and work here, people's previous experiences and what they were very clear about their previous experiences and what they wanted to be different actually moving forward. So one of the things that people felt wasn't very helpful was when changes were made and they seemed to be sort of in a sense dictated from the very top level down, and staff didn't feel involved in making the changes on the frontline services. So they felt that that was quite important, was something they wanted to change. And I think QI beautifully links in with that, actually empowering people and giving them the skills to make the changes that they know actually are really important for the service users and the carers and the work that they do as frontline staff. Secondly, the whole involvement, there was already quite a culture of involving carers and service users in engaging them in services here already. And then QI sort of built further on that by making sure that carers and service users were trained up in the QI methodology, and also taking part in QI projects, because obviously their input is critical really in informing and working with us in terms of improving the services. I think what's been helpful as well is that, as was mentioned earlier, that the Trust at a very high level has over the last few years been committed to quality improvement of the services and involving staff and carers and service users in delivering that, rather than dictating from the top down. So I think the leadership they talk about being sort of quite consistent in that sort of philosophy, if you like, and culture has been quite important in helping QI develop and supporting that here. Also sort of use of RIO and reporting services that will help and assist people in looking at how more easily evaluating the changes that they're making and the outcomes they want, so making that easier for people. What did we talk about at our table? So I suppose that's probably the main things, the support from the Trust at the top level all the way down, and also the experience that the Trust has had, because they've been running this for 3 years, so they have a very experienced team at Trust level who are able to then share that learning with us here in Bedfordshire and Luton. And also I think it's probably quite positive for people to see that things can really improve and change, and that encourages people to see the value of QI. So for example, in East London, the reduction of violence and aggression, which is obviously a very important subject, that has really been improved enormously by QI. So I think that seeing the success in East London also encourages us here, and also obviously today, events like this, where people get to showcase their projects and actually show how they've been able to use the training to deliver sort of improvements. So I think all of those together has really helped QI.
Thank you. So the next question is for you, Eugene. So what are your initial thoughts about what we've heard so far about what's been hindering QI over the last year, and what could we do to tackle some of these obstacles?
Okay, thank you, Oz, and welcome everyone. It's been a great conference so far. I'm really enjoying it. I think there are some areas that we need to focus on. They've come back through the feedback on your tables. There are some themes that certainly I picked up. I think they're around time and commitment to the QI process. We appear to be on occasions thinking that this is an add-on. Certainly that came through from our table feedback. And what we need to do, I think, is actually try and incorporate this into business as usual. So this is how we apply our thinking and approach to issues that arise in the workplace. I think the other factors which have been around are around the availability of coaches. We need to ensure that there are more coaches available to support projects, to support the initiatives that are going on in the clinical areas. We have in Bedfordshire and Luton, we have a coaching training program coming up shortly, and we've identified more coaches to support both the existing projects as well as new projects going forward. That's really important, that those people who have those initial ideas and really feel passionate about their areas of development get that early support and ongoing support to see those through to the end. We also have, I think, some other work to do around how we engage the workforce fully. We heard on our table, and I don't know if this resonates across some people in the room who really aren't engaged in the QI process, haven't heard that much about it, and these are frontline workers. And I think if our philosophy is engagement of frontline workers, we need to do a bit more on that. We really need to engage people in this program. We need to get that grassroots buy-in, and we really need to support those staff with their ideas, with their initiatives going forward, because they are, those ideas are very important, and they might be the thing that cracks that issue, cracks that problem, improves clinical care, improves the quality. The people on the front line, the people who are working clinically in that area, they know what the issues are, and they will all have ideas about how to overcome those. And we need to create structures and mechanisms to elicit that and support them from whatever level.
Great, thank you. The next question is for Claire. So Claire, QI is about engaging people, bringing joy and fun into what we do. So from your experience across the trust, what have you seen examples of this type of fun engagement happening?
So there's a new and exciting project that's coming up in the Luton wards, and the start of this is thinking about, one of the key priorities is thinking about recruitment and retention. So we know that this is something that every team worries about, and as fast as we recruit people, if they're going out the other end and are not retained, then we're making no gains. And what we know is that a good, stable workforce is the foundation for happy staff and great service user experience. And lots of temporary staff has the opposite effect. So Luton, there's 2 wards that currently have challenges with retention, are going to look at how at small scale changes that they can make to think about how can we retain our nursing workforce. What we do know is that people want to stay in teams where they're happy, where they feel supported, and where they really feel like they're making a difference with service users. And if that's our cornerstone, then we have to come up with innovative ideas about what are the magic ingredients that make a team feel like that. And I think in leadership and in management, we have some of the solutions. So supervision, appraisals, QI, all of those little initiatives, but there's a magic ingredient. And I think it's the people on the floor at every grade and the service users that will tell us, because you sometimes meet these teams where it's maybe the most challenging teams with the most challenging service users, but for some reason it works and everybody enjoys working there. Retention is really high and service users rate their services really highly. So what is it that makes that? And I think that our staff can tell us that. And so that's a project that I think will certainly bring happiness and greater happiness in the workplace.
Great, thank you. I'm sure we'll all be looking out for that project. So Neil, so you work as a QI coach in Luton. So you've got a lot of experience over the last year supporting teams. Any stories you care to share?
I think firstly, what I just want to mention, these chairs, as inviting as they look, they're not as comfortable. So please don't be jealous of us sat up here. I think quickly, I just want to reflect on the past year. I think everyone in this room could probably agree, and it resonates across the whole room, that it's been difficult. It's been a challenge, it's been hard, it's been a fraught road. But I think there's not one story that sticks out. It's the stories of all the project teams that I've met and what I've heard. Everyone has been so passionate, so enthusiastic, and given all the challenges that we face in Luton and Beds, it's just been amazing. And finding the time, and people are still willing to find the time, willing to put the effort in, and even maybe the projects aren't on QI Life, maybe they're not officially registered or there's no coach input, the quality improvement work is still going on. So irrespective of the challenges that we have been facing, people are still involved, willing and engaged. It's just like my colleagues have said there, it's just capitalizing on this now and really taking it forward and having some fun with it.
That's amazing. Thank you. So Satwinder, so you've been a service user on teams working to improve their services. Can you share your thoughts on your experience, but also, why it's important to have service users as part of projects working to improve services?
Right, firstly, can I just say thank you to the people who've made it possible for me to sit in this chair today, even though it's not comfortable, as Sunil said. But anyway, the Diverse Cultures team, People Participation, Camilla, and Recovery College, thank you for making this possible for me. And the question again, please.
So you've been involved in QI projects, just your experience of that, and why you think it's important to have service users as part of QI projects?
Well, firstly, I think it's amazing to be able to walk in to an inpatient ward where you are actually an inpatient and sit with the staff and the psychiatrist and be able to have conversations about how it is run. And when I first went in, we all wrote our little bits, and with NIN, I couldn't understand. It was, everybody was saying different things. And all I would say was, yes, but the service users, that's all. Obviously, that's going to come to my mind. Yeah, but that's just their needs. But what I wasn't looking at was ultimately all these things that they are doing end up helping the service user. So the PDSA, NIN's on the project with us. And the PDSA does actually help. And I do feel that the QI training as well, if you can get onto that as well, which Camilla made me do, didn't you? Yes. And I have to say, Mr. Potato Head is still in my head. And if anyone's been to the QI, pocket QI training, you'd know what I'm talking about. Anybody? No? Okay. Yes? Good. It's the, how long it takes you to make Mr. Potato Head's face exactly on the picture, and then you have to find the best way you do it and the littlest time, and basically it's using your PDSA cycle. And the other thing which I really, really liked about your training, which I can relate to the way, when you're on a project, for example, I'm on Keats ward bed occupancy, reducing bed occupancy. And initially when you think of it, you think, well, hang on a minute, don't people need to be in their beds there? But then when you see the sort of positive outcomes that can be brought to reducing the bed occupancy, where people are allowed to do other things, or there's other networks which are going to help them out, and things like that, you can see, and you're empowering the patients as well. You can see how, reducing the bed occupancy is a positive QI project. So, I mean, the other thing is, yes, you do have to sort of have, because obviously planning, and we have to see which is going to work. Timing is always a very tight thing, because, I mean, although I say, okay, 12:30, and then, somebody might get held up or something, I always find the timing thing is a key thing that we need to sort of get together to make it more effective. And then I think, just to end with, I think I'm going to have to say bingo to Ishraf. Because when we first did the training, they gave us a sheet, and what we had to do was we had to find characteristics of people in the room. So, for example, you drive, you ride a bike, you have a dog, you like football, so something like that. And the way I got my bingo quite quickly was listening out to others. So when I heard somebody say bike, I'll run over to them to get that answer. So I can actually see how communicating and finding those easier paths to dealing with, the bigger things in the system is possible. And QI, I actually am starting to like it now, because at first when I went, I thought, no, graphs, figures. How can you possibly explain mental health in terms of numbers or graphs to me? But then, yes, to make it more workable, those numbers become words and meaning and help.
Great, thank you. So Camilla, we've heard a lot already about involving service users, carers. From your perspective as a people participation lead, what have been some of the challenges and successes of doing this work over the last year?
I think I will start with the successes first, because I feel very privileged in this job to be working with these amazing people and trying to find the opportunities and give them the ways of feeling empowered to take part in the QI projects or any of the other areas that I involve them with. So Thank you, Sadrina. It's amazing. Thank you. I think we have been very, great in Bedfordshire because we have had great response from service users. They all want to be involved and are very keen. And we have also worked very hard to involve people from different backgrounds. So it's not, we get a perspective of other people other than, the usual people that give feedback. So that has been very good. And we have got a great will amongst service users to be involved, which brings me on to the challenge because obviously this is quite an innovative way of working and co-producing services with service users, which maybe sometimes people can find a bit, feel a bit worried about it. So we just say, try it, it really works. And they bring such unique and different experience and ideas to the table, which can really make a great difference within the QI team. So yeah, we are here to help as PP leads, my colleagues William and John and myself. So if anyone needs any help with involving service users, please come and speak to us.
Thank you very much. So a final prepared question is for Stephen. The easiest question of the afternoon, which is one of the big challenges is our requirement to find 4% cash releasing efficiency savings each year. How do you think our QI approach links with this?
I think before I answer that, I'll just say I think the fact that the QI training includes graphs and figures is wonderful. So just want to start there. Yeah, finding efficiency savings year on year for the number of years we've been doing it is extremely challenging. I think to say about QI, firstly, it's not about making savings and efficiencies, it's about improving outcomes and experience for service users, carers and staff. What we do know is that a quality environment and a quality system will actually cost you less money in the long run. And I think that's really where QI comes into its own in helping us with that challenge. I think if we look at some of the projects we've seen today, sort of the first two that were demonstrated to us, you can see that they were sort of really focusing on some of the inefficiencies in their systems around duplication, around rework, and around things that were taking far longer than they should have done. And I think lots of the QI projects tend to find some of those, whether they be bottlenecks, waste, or duplication, things of those nature that help us to become more efficient in the way we deliver our services, and by doing that we can create an efficient system as well as a quality driven system that in theory will cost us less over the longer run. And I think that's probably where we've got to. We haven't necessarily used QI in the early years to deliver some of our efficiency savings. So what's different now? And I think that comes down to the challenge of continually trying to make our money go further and providing best value with that. And the danger is that we can end up making decisions around how we achieve efficiency savings that perhaps deliver a short-term benefit but not long-term. What we know about QI, and we've seen today, is one of the benefits and the enablers is that it is a bottom-up approach. And I think some of the best ideas of how we become more efficient are out there. It's you guys sitting around the tables, it's your teams, it's your staff, it's your service users and colleagues. And it also provides a structure on how we can work towards a more efficient system as well. So rather than seeing it as a never-ending problem, a challenge, I think it's using QI as an enabler to help us achieve those efficiency savings in the longer term, year on year.
Great, thank you. Actually, one of the questions you've already answered, which came up, was, do you have any, where was it? Do you have any projections on how adoption of QI may improve the trust finances in this time of limited budgets, but increasing demand?
Yeah, I think you're right. I probably have answered most of that, and it really is about using QI as an enabler for us to do that, to really think about what our budgets are, what our financial envelope is, and how we can deliver, as you say, an increasingly services that have increasing demands put upon them. And that really is going to be about how we can provide those in a different way, create different pathways, different systems, but more efficient and more quality-driven systems to do that.
So one of the questions we have is actually linked to one of our presentations earlier, is how can we enable shared leadership across services in relation to developing quality improvement. So how can we enable shared leadership across services? Who would like to tackle that one?
Okay. I suppose I think the task of the managers and leaders is to understand or to hear and understand what's being said by the staff about their priorities, and then they become enablers to support teams to work out those problems. So I believe that leaders need to think about the gaps and the kind of the obstacles and really help them to unlock that so that they can come up with the solutions and push things forward. So I think that's the partnership. We become the enablers for stuff to happen.
Excellent, thank you. Now we've got 2 mics, so if you'd just like to raise your hand, we can take a few questions from the audience as well. Any takers? At the front here, please.
I'm coming.
We've had an inspirational morning with lots of really great ideas, but I think some of us may be feeling a little bit frustrated, just wondering, how do we actually put this into practice? You know, there's this bottom-up approach, which sounds absolutely wonderful. Talk to the people who are actually providing the service and using the service to work out how we can do things better to improve quality within the financial envelope that we have. But how do we actually put that into practice? Because it's, dare I said, there may be people around the room who are thinking, yes, I really want to do this, but tell me how.
I think my advice is just get involved. Just get started. We've got coaches all around Luton and Bedford. We've got the sponsors. Come and talk to us. Just come and talk to us, get involved, and don't be scared of failing. There's no such thing as failure in QI. There's only learning. So yeah, just come and talk to any one of us, and we're more than happy to help you. I mean, yes, there are competing demands of the day job versus QI and all that sort of stuff, but please come and talk to us, and we're more than happy to help you get your project off the ground.
Great. And Zelfa, would you like to add to that?
Yeah, thanks very much. Yes, I also think it's about how all of us communicate with each other and engage with each other. So, for example, even everyday things like, you know, somebody who might be a band 3 or a band 4 on a ward can have a very sort of valuable input into, say, ward decisions, ward rounds and so on. So it's actually giving the message that actually it doesn't matter what, you know, in terms of hierarchy where you are, but you can have a very important input into the services and what's important and how to move things forward. Also, I think it's about when we're even changing services, how we go about that, actually making sure that we organize meetings with staff, we get their ideas, and not just get their ideas, but they can actually then see how their ideas have influenced decision making, for example, in terms of service development. So I think that then creates the idea that actually we're all working together as a team in the directorate, and that everybody has a role in that. So that then will lead to actually people feeling that actually, if I have more of these sort of, you know, training and skills, I will be allowed to actually influence the direction of the services. So then encouraging obviously more of the team managers, consultants, you know, to sort of do the training and then start to bring it up within team meetings actually as to, okay, we're having a problem with an increase in referrals, and actually we've got limited capacity within the team to quickly, for example, assess patients. How might we begin to tackle this? Is this something that could be sort of used, QI could be used to actually address this real life problem? And then obviously the QI coaches and so on, supporting the teams then to actually then come up with a project and come up with ideas and test them out, and then hopefully sort of see that the impact of that is that they are able to manage the demand and still see people quickly and, treat people in a timely manner. So I suppose it's about all of those things together, not just sort of, the training and encouraging people to go on, but actually how we, in our day-to-day sort of work, ensure that actually we're not the experts, people in more senior positions are not the experts and have all the answers, but actually it's all part of the whole teamwork and everybody's point of view and opinion being very important and feeding into the best outcomes for the patients.
Great, thank you. One more question from there, please.
Hello, we heard from Chris Hamm, who said that the key to leadership and success is partnership between experienced managers and skilled clinical leaders. So do you think the QI project in its current gestation is now ready to go to the next level, sort of working with external agencies such as housing or other organizations, for example, to reduce length of stay?
Who would like to tackle that? Eugene?
Thank you. Yeah, I think we, this is a journey that we've started. I think we're on a journey now in terms of moving forward. So we're looking internally. I think we're looking inwardly in terms of our processes, our systems, improvement within ELFT and the services that we provide. But there is an opportunity, I think you're right, to extend that into other sectors, into other ways of working, and integration is something that certainly came up from Chris Hamm's presentation. And it would be about how we can improve the quality of our services beyond what we provide within ELFT, within primary care, within community care, within other sectors. And I think that is a really exciting opportunity to engage partners in that initiative. And we have people from commissioning backgrounds with us today in the audience who will be also interested in improving quality. Everybody is interested in that. And this is a tried and tested methodology which has been successful here in Luton and Bedfordshire. And we can potentially roll that out into other sectors to improve the quality of outcomes for patients and carers within the healthcare system and indeed within social care.
Can I just add to that, please?
Yes.
Working, but I can say it anyway. It's funny that you should mention housing, because in Keats, when we are talking about reducing bed occupancy rates, that is one of the areas where we have been looking. You need to make links with these external housing and other things that they will be able to access to ensure that the bed occupancy rates go down. And the external agencies, I think, are very important. And already, I think, it's all in there at the moment. Thank you.
Great, thank you. So one other question that's come through is, how can the senior leadership team free people up to spend time working on improvements? Eugene?
Okay, I think it's really important that we do that. I think that there are, on occasions, wasted effort. We're actually doing things, we're struggling with problems, we're trying to find solutions which either are out of our grasp, or they're not successful, or we're not collaborating around them. And I think that there is some time already in the system which we are using not to best effect. So I think there is some capacity that we could use by utilising this methodology, by using the QI approach and techniques, which is already there in the system. There are people, though, so we know that the frontline workers are delivering clinical care, and we need to continue to do that. We also need to develop our quality initiatives, and it is really important that we free up time. So that's why we're looking at coaches having protected time to go out and support projects. We can't expect people to do everything, and we can't pull them in multiple directions. So we need to invest in this in terms of that time, and I think it's a really important question. It's in terms of engagement, and there might be in terms of those initiatives, it might be something that we need to prime. So the early initiatives might need more time out of the workplace, people to get together to develop their ideas and brainstorm in order to develop those new projects, those new initiatives.
Great.
If I was to link that to the QI project that's happening that I talked about earlier, there's a cost to save. So the reality of working with lots of agency nurses or bank nurses means that you are putting double the effort in every day. But to change that effort to be proactive and to think about, all right, what are we going to do to retain staff so that we're not it doesn't feel quite so hard, means that you can get to a different place in the longer term. So it is sometimes looking at the long game and thinking, where are we going to that will make a difference to the task that we're doing today, doing tomorrow, and kind of making small steps towards. But linking to Eugene's point, there also needs to be some recognition of time and what support that needs.
Great. So maybe we might just link that in with just one more question that's come through. Neil, do you want to say something?
Add on. Time comes up a lot, especially questions you get as a QI coach, and we never have enough time. I challenge anyone in this room, myself included, there's times in the day where we sit around twiddling our thumbs, we do procrastinate, or we drag out things. We need to be a little bit more creative in our use of time. Remembering a QI project, you don't need to be meeting hours every day. A quick 5-10 minute burst per day, every other day, can also help tick you guys over with the project as well. So it's not a case of dedicating so much time to it, but it's a case of working smarter, not harder.
Great, thank you. So it sounds like really complex problems that we really want to think about how we work through them. Really, our final question has had the most votes on Slido, and it's directed at Zelfa. I know we've touched on it already. Oh no, it's Zelfa who posted it, so I wouldn't pose it to her. But I'll read it out on her behalf. That's why
I asked the question.
But it was a good question because it got the most votes, which is, how can trust survive and maintain staff morale in the face of these huge challenges? So maybe we'll leave you with that question. Because you'll notice that on the 3 post-it note exercise we did around the tables, that theme comes out again, and we'll be discussing that a bit later. So can you join me, please, in thanking our panel? So thank you all very much. And it's my pleasure now to introduce a friend, not just a friend to improvement or healthcare improvement, but a friend to ELFT, and also someone who's worked with the Institute for Healthcare Improvement, Europe, Latin America, Pedro Delgado.
Thank you. Is this working? Are we on? Yeah. Well. Hi, everyone. It's great to be here. Amar, Navina, Jonathan, Mason, and everyone here. It's been such a privilege for us as an institute to be part of this journey. By no means we take any credit for it. We hugely admire what you're doing, and to have the news today of the staff engagement results is pretty amazing. So what I thought I would do today is just to tell you a few stories. And walk you through some things that I've seen. So I'm gonna do a couple of context things just to get us farther in here, and then I'm gonna move on to some stories. The first one you may have seen before, and it's this. And what I want from all of you is just to take 2 seconds to pick one card, your favorite card. Just pick it. And the time's running down and almost out. So pick your favorite card. Has everyone done it? Okay. And what I'll try to do now in this interaction is just to take your card out of this pack. Whose card did I take out? That's pretty clever, huh? Of course, is if the first principle of improvement is that every system is perfectly designed to get the results that it gets, and that flows through our cognitive vulnerabilities. And this is one of them. When we focus on one thing, even though we have to do a million things like we all do in our lives, sometimes we miss things. This is obviously a different deck than that. So I haven't done anything magical. I just changed all the cards. So of course I took everyone's cards out. The second one is just to, and this is why I titled this talk Improvement Stories and Learning. It's the ontological coaching equation. We see the world not as it is, but as we are. And I've seen it repeated over and over and over again today when you've given feedback to the challenges that you have, to the things that could be improved. You've told stories about what you're doing to improve and so on. And the formula is pretty simple. The observer that we are, plus the actions that we take, lead to results. And the tendency for all of us is to just go here, to just say, okay, we'll just change the action. We won't touch the observer that we are. We'll change the action. And then things will change. This is second order learning when we constantly just challenge ourselves to acknowledge and sort of make that very, very deep, accept the fact that we see the world as we are. And we bring a gift to the world in that way, but it also makes us vulnerable to our tendencies, which can be fantastic, by the way. This is not a weakness, but an assets-based kind of thinking. So let me from there tell you some things that I have observed personally. These are Berta and Tomás, and this is Chiapas in rural Mexico, okay? Berta kept showing up. This was an improvement project. She kept showing up in the context of Jafet, who's the author of this article, validating an assessment tool for quick diagnostics in a context that has no psychiatrists, no psychologists, just some primary care people, okay? So that's a context. And she kept showing up. She kept showing up and saying, the what's the matter answer was, my back is sore, I have a headache, I can't sleep, my tummy aches, I have digestive problems, and on and on and on. And she kept coming. As we looked at the system, and we were trying to understand why in rural Chiapas, this is in the middle of nowhere, the prevalence of mental health conditions was a fifth of what it should have been. Something wasn't right. So we needed to do something different. When we started this journey, we sat down with Berta and said, so what matters to you? And she said, actually, based on my history of abuse and a broken marriage and lately unemployment, what matters most to me is my son. What about your son? She says, well, I suffer a lot because they call him el loco. El loco means the nutcase in the town, and they chase him and so on. So I've had to revert to chaining him. And if you look at the left ankle of Tomás, that's a chain to a tree in our garden so that people do not bully him in the town. He's been like that for the last year and a half. That was exactly the time that she started showing up to this primary care practice where people kept looking at the symptom of the tummy ache and the headache and so on, as opposed to asking the question. We had the assessment tool that we were prototyping. She took the assessment tool. She was severely depressed. The body language shows that. Tomás was a schizophrenia patient. Tomás was then brought in. We worked with Tomás, and Tomás is now actively working. Berta is back to selling food in the streets and so on. When we talk about improving health and healthcare worldwide, when you talk about being the best community and mental health trust in the UK by 2020, this is who we do it for. It's the people that we serve. It's the people that live in Bedfordshire, in Bedford, in Luton, in London, and on and on and on. And you also do it for each other because you're building an environment to work in that's absolutely wonderful. And I've seen it. This morning, I borrowed a couple of these slides when we talk about assessment. It's assessment in the service of Berta, in the service of Tomás, in the service of all the Bertas and Tomáses that you may have here. The language that they used in Mexico to describe this is structural violence. Isn't that a term? When your structure is so messed up and so absent that people are suffering. So you're not punching anyone. But the suffering that's happening underneath, it's quite severe. The second story is a bit more technical, and it started in a beach in Rio with a conversation that just happened to happen. The regulator of Brazil, of the private sector, was being sued by the public prosecutor. They were being sued for obstetric violence. A public prosecutor called Marta, the director, and said, Marta, what's going on? You've got regulations all over, and our cesarean section rate is the highest in the world by a mile. The C-section rate in Brazil is 85%. The recommended rate is 20. Now, that's a gap. So in that conversation, she asked about how can we add to all the regulations that we have many. How can we add something different to see if we can make a difference? Otherwise, the regulation agency is going to disappear. And of course, I talked about improvement. I said, why don't we enamor some hospitals to demonstrate in Brazil what's possible and take it from there. Thankfully, we had an improvement project that we had just finished that had taken the C-section rate in a hospital from 97% to 50%, which was quite remarkable in Brazil. So we started with an aim. The aim wasn't to reduce C-sections because clinicians were going to feel attacked. They suggested that we increase vaginal deliveries, and we call the effort parto adecuado, adequate birth. Because sometimes having a C-section is an adequate thing. So I wanted to illustrate the 5 components of design, which I know you use, and I've seen them today through this project. So the aim was 40% by November 2016. We had what I've seen today a few times, a driver diagram with an aim, primary, secondary drivers, and change ideas. That was co-developed with local leaders and global leaders and so on. We had an execution theory that was largely about doing what you're doing here. So we knew we could enamor a group up to 30. We finished with 26 in the end from throughout Brazil. And we got them to collaborate, to share data, to have conversations, and on and on and on throughout Brazil. And we articulated at the time a logic model to understand what inputs we needed, what activities we were going to do, what outputs we would get out of that, and what the outcomes that we would achieve would be. You don't need to read that. That's a logic model, part of the execution theory. And of course, we measured, and we measured in the way that you measure, which is data over time. And we measure, and we celebrate, and we learn, and we measure, and we celebrate, and we learn. The results by November, which we celebrated, were 10,000 C-sections that were avoided, 400 neonatal ICU admissions for newborn babies that were avoided. That's why we're doing this. That's why improvement and regulation hand by hand. That's why having a method, as Chris suggested, is important. It can make a difference, and that can be powerful. So powerful that you can get clinicians and managers, as Chris suggested, and these are 2 of those, celebrating the fact that those incubators were full before, and now they're empty, because they were able to increase vaginal deliveries and reduce C-section rates. And we have some narratives from local obstetricians who are now doing things extremely different. And of course, working with 26 is one thing. Being very intentional about how we can make that happen throughout Brazil is a very different thing. So we we're using, and we used this with a group from East London about a month ago. We're using a scale-up framework that describes the phases of scale-up, the support systems, the adoption mechanisms to get us there. It's intentional. It has elements that are designed, and it differs from phase to phase. The driver diagram from phase 1 with 26 is different from phase 2 because we've learned. The logic model from phase 1 is different from phase 2 because going from 26 to 150 is quite different. And the scale-up model helps us to articulate that. We've gone from a central hub that serves or supports 26 hospitals throughout Brazil to building 10 hubs throughout the country that will support the entire movement. That starts in April. We had the first call yesterday, and there were 130 hospitals on that call, which was pretty exciting. So that's a Brazil story, and that one's around intentionality, but it's also grounded on people and that partnership. The third thing I wanted to do was just to reflect with you on 3 small things that I've observed as an athlete, as a healthcare professional, as a husband, as a brother, and so on, in terms of leadership. The first one is this common denominator of leaders who are fantastic. They're not heroic by any means, but they do strive to leave a legacy with humility. So they know what they want to gift to the world around them, and they do it with humility. And I'll tell you a quick story. We did try to work a short video so you could hear these kids playing. So this is the story of El Sistema. Has anyone heard of El Sistema? So El Sistema is a program that was founded by a guy called José Antonio Abreu in Venezuela, which is where I'm from. That's why I know the story well. About 30 years ago, José Antonio is an economist who had a dream. His dream was to ensure that kids from vulnerable areas would hold an instrument instead of a gun as they develop. So El Sistema is a system, as it sounds, of orchestras throughout Venezuela that do that. They get money to ensure that kids have an instrument in their hands. They create orchestras so that they can start teaching them about discipline, about practice, about teamwork, about harmony, about coordination, and so on. And 30 years on, El Sistema has produced not only amazing orchestra, they play at the BBC proms almost every year. These are kids from maybe 9 to 15, but they've also produced people like this guy here. Rafael Dudamel is the director of the Philharmonic Orchestra of Los Angeles. José Antonio Abreu didn't want to build anything to create the director of the LA Philharmonic Orchestra. He wanted to change a gun for an instrument, and he wanted to leave a legacy. He's still alive. His health is not very good, but this is what I mean when I talk about legacy. The second couple of points here comes from my own experience as an athlete, and that's me in the picture in the middle at the top. And these are 2 of my coaches who I love dearly, I must confess. They're from Uruguay. And they're wise people, at least in my eyes. So I wanted to talk about rituals. These guys had rituals. Rituals that we loved. The guy at the top, Carlos Ravel, he, let me share this story. He called me, he said, hey, you know, I have an idea and I want to build a project around you. And when you're young and you're a player and somebody says, I want to build a project around you, you feel important. And then I asked my teammates about a year on, and they said, he told me the same thing. He wasn't lying, of course. He wanted to build a project around all of us. And that's how you build a team, right? But he had rituals, and that cup there in the middle is a tea that they drink in the south of South America called mate. So what you do is you pack the cup with herbs. Mate is a plant. And then you pour hot water, and the straw is a metal straw. So Ravel would call you once every couple of weeks. We trained at 7 in the morning every day to sit down with him to have a mate. So you should come at 6 in the morning, and have a conversation with him. And you knew that out of that ritual would come something fantastic for you as a player. Ravel sang on Wednesdays with us. Don't ask me how he came up with these silly songs, but he had us singing right before training. He just started a rhyme and everybody followed, and he got us into the mood on Saturdays. We played on Sundays. He made barbecues. In the south of South America, Argentina and Uruguay, they have amazing meat, and they know how to make barbecues in a fantastic way. And that all served to build a culture, build a team. There were rituals. He didn't call them rituals. That's my labeling, but they were rituals. We knew that they would happen. We sort of got into the groove, and we knew that they would create. Not that the result of that was all linked to only the rituals, but that served to create a culture. We won 26 games in a row. We were promoted to the top division and so on. And then I played under this guy on that team. And Kata had a couple of things that he did. The first one, it was funny to watch once it happened to you, because you knew that it would happen. When a new player came in, he would do this, and he would do this. He would say, in my experience as a coach, I see that players come in like this. Give me more money, give me more stuff, give me a house, and I think players should come in like this. What can I add to the team? How can I contribute to what we're trying to build here? How can we? So his gesture became something that we observed. He grabbed the player and he did it in the middle of training. He would take them out, and we would all sort of wait for the moment. You would see them in the corner and we would all be peeking, but he would do the hand gesture every single time. The other thing that we did, and this was funny at the beginning, and then we sort of got used to it. We played against a number of people who, say, played in World Cups and so on, and he would get their uniform with their names on their back, and the night before the game, he would gather us in the hotel, and he would say, hey, whoever, Carlos, come over here, wear that jersey. Does that jersey make Carlos any better than what he is? Tomorrow it's 11 against 11. We have all we need. We've done our homework. We've done our work. So let's get out there and make sure that there were rituals that made the expectations predictable. And they also built a culture. And the question around the rituals is, what kind of rituals, what kind of regular meetings or conversations and so on do you have? And the third one, in terms of leadership, is this generosity with power. Generosity with power. And QI, and many of you may have seen this slide, we use it often at IHI. It was co-produced with our friends in Scotland. Chris was talking about politicians and regulators doing no harm, something that I really liked, actually. I hadn't heard it before. But our history in this publicly funded system is that we've been target-driven. And these are things that are imposed, and this kind of leadership is about keeping power. The kind of leadership that you're displaying and you're actually showing the way, not only to the rest of England and the UK, but the rest of the world. And it's hard and it's tough and sometimes it feels impossible. It's about sharing power, and it's using continuous quality improvement to do the work that you do in delivering better care, producing better health at sustainable costs. And the third one, which is something that's ongoing and a forever piece of work, is this idea not only of sharing power, but of seeding power, which is the creation of a movement that cannot be stopped, because the reality is so dramatically better than what it was that going back, it's just not feasible. So those are three reflections on leadership. Striving to leave a legacy with humility, building rituals that build cultures, and generosity with power. So as you continue on your journey, I'm excited that we can continue to observe what happens. I'm excited that we can help to disseminate the lessons, and we admire hugely what you do every single day. As always, thanks for having me. Let me finish with a quick video that will perhaps Not sure if the reality is like that here. Perhaps tell you a bit about change and the challenges that you may encounter when you're trying to do things differently. This is a video about social influence. And you're allowed to laugh if you so feel, by the way. So let's see if it works. Should it work on the click? Should we give it 20 seconds and then give up? Yeah. Is it easier to copy paste? Yeah. Let's just try this. If this doesn't work, we'll just go on. I have to move it across. Are we doing questions? Yes. Okay.
So I would like to take a few questions from the audience. So if you have any questions, please just raise your hand. For Pedro. One here.
Thank you, Pedro. And that was a really all-inclusive talk in terms of the frame of references you brought in. I thought it was amazing. And I think what's wonderful for us is the range of organisations that you've dealt with and are still working with. And it'd be really good, I think, to hear your perspective on what ELFT is particularly good at, and also from the other organisations that you've worked in, the areas where you feel we should be focused and perhaps we could perhaps do better compared to others.
I'll answer the first part of the question stronger than the second part, actually. I think you do a lot of amazing things. One thing that I think you're doing effectively is you're changing the language and the power dynamics. I think the way that you, even though you feel like you don't do it perfectly, and none of us do, I think the way you partner with patients, not engage patients, but partner with patients, is quite something. It's pretty unique, actually. I think the kind of exercise that you did today, where you engage over 100 people in a room to say, what are the barriers? How can we be better? Is something that you do pretty spectacularly. So I think the partnership with patients and the partnership with staff are two things that are changing the landscape of healthcare. I think it's one of the things that I often get asked about in terms of your work. The second thing, and this is a discipline issue, I think, it's how disciplined you have become at using improvement in systematic ways. There are some organizations, and perhaps many, who are using some improvement in some places to varying degrees in terms of the application. I think in East London you try to be very systematic about how you go about it. QI Life is an example of it. The way that you do measurement now, from a dashboard perspective at the board level, is quite something. So that is building a culture in ways that I have not seen in many places around the world. So yeah, those are pretty unique things.
Thank you. Any more questions? Maybe one from me, Pedro. What's the meaning of the video? What should we read from that video?
So you can pretty much read from my talk and from the video whatever you want. I'll tell you what I read from it. Sometimes it's hard looking the other way. Because the world just takes you in a certain direction. And you may not want to go in that direction. It may not feel right in here. May not be able to articulate why, but it may just not feel right. Like that last guy, he was having a laugh with himself. He's like, what the hell am I doing? I know the door is there. These guys are nuts. So sometimes if it smells right, if it feels right, if it looks right, just dare to look the other way.
Great. Thank you very much, Pedro. So finally, we'd like to invite Richard Evans and Claire McKenna for just a closing summary.
Hello, everyone. Well, it's been a fantastic morning, hasn't it? And Claire and I are here really just to sort of briefly summarize some of the things that we've heard and perhaps some of the things that we've learned. And it's difficult because there's been so many good things about this morning. And of course, coming after Pedro's inspirational talk is not the easiest thing to do, but we will be brief. And at the end, I'm going to tell you how to go and get your lunch. So that's coming. I think really just to say that I thought that to start off with those two QI projects was such a great way to begin the morning. I don't know what you thought about that.
Yeah, I think the presentations to me showed that what seemingly feel like small changes can make such a significant difference. So you can imagine if we do hundreds of those little changes, that will just make, yes, it will be amazing. So I thought they were really great examples of what QI can do and the difference it can make.
Yes, and I thought that certainly, I think in the second presentation, when the trainers, were surprised by how quickly things changed and perhaps how it sort of made their jobs easier. I think that's one of the things that we really want to sort of be able to share, so that people realise that if we do spend, as has been said earlier on, if we spend a little bit of time on our QI projects, actually it can actually make our jobs less pressured and make us more effective. So that was great. And I think then after that we went on to Professor Hamm and his sort of his talk about reforming the NHS by quality improvement, and he gave us some examples of organisations that do that particularly well. And I was struck by the concept of good leadership being collective and shared. And then I think that one of the other things that he talked about was how we need to value our staff, because of course we need to utilize their creativity, our creativity for innovation. So it's very much about listening to staff and giving them permission to get involved in changing their service. And then if we do that, great things happen. And then I think we went on after that to talk about the progress that had been made.
I suppose in a relatively short space of time, the training of 200 people and having 41 projects live is just astounding. And I think my experiences from going around the clinical areas is how keen people are to start thinking about QI. And I think thinking with the QI team, they're saying in training, the enthusiasm and the desire to kind of get on board and really make changes is palpable. So I think we've got the foundations of something that we can really build on.
Yes, I agree. And then we had the messages from the sort of national and international partners, which was great. And then after that, we had the panel, which I really enjoyed. How was it for you?
Not quite so good, but yeah.
But I thought there were some really insightful things that were said by colleagues on the panel. But what I really liked was Satwinder and her contribution, which I thought was extremely compelling, and Camilla talking about, as a people participation lead, how there's so many service users and carers out there who want to be involved and how important that is. And so I thought that was a very sort of interesting and enjoyable part of the morning today.
And certainly I've seen real evidence of service use as being core parts of teams and really making a difference in thinking about being partners in coming up with creative ideas. So I think we have a real strength in Luton and Beds to build on.
Yes, and then of course we had Pedro's fantastic talk, and as I said, I found his stories of quality improvement really inspirational, and I think you found Pedro inspirational as well, didn't you, Claire?
Moving on. I'm blushing.
So it was really great, and we're very fortunate to have had him come to talk with us today. So of course the other thing that we did was we asked people for their ideas as to what we should be focusing on as we go forward, next year and afterwards. And I was hoping that we may be able to look at those and perhaps vote on them. But are we able to see those? Hopefully. Okay, so apparently the poll has gone live. One of the things that we were hoping we might do is be able to see some of the ideas on the screen. But if people want to vote anyway, and I think what we're after is the things that you feel are priorities for the organization that we should incorporate into our quality improvement work, as I say, over the next weeks, months and years. Should we give people 5 minutes to do that?
The tech was destined to fail at some point, yes, wasn't it?
Oh, fantastic. That's really good, isn't it? I have to have a look at it. Staff retention is clearly something that a lot of people feel is extremely important, and I think we had some very clear messages from people about that this morning. We know that we need to improve communication. Have you got any comments about some of the priorities?
I suppose care pathways make sense in the transformations that are happening. So thinking about the complete care pathway makes sense that would be one of our priorities. And access to service links to that nicely, doesn't it?
Yes. We've already outlined that we want to reduce harm. And I'm glad to see increasing service user and care involvement and increasing the stakeholder engagement is important to us as well. So I think the promise is that we will certainly be taking all this information away, that we'll be coming back to you, we'll be continuing to ask you and to listen to you about what we need to do. And although we have trust priorities that are general umbrellas that we need to sort of think through, what we really want is for your excellent ideas within those contexts so that we can develop quality improvement projects and change the service accordingly.
And I suppose what we might need to do is understand improving communication, what that means, and really drill down to make sure we're making the right next steps.
So I think really that's probably what we wanted to say. Really, just thank you very much, everyone, for coming. Thank you very, very much to everyone who's been involved during the morning. It's been extremely informative and enjoyable. Without further ado, just to say that lunch should be served. If you go through that door on the left, you go through to a big room where you can get the food and then bring it back to the cafe. So please enjoy your lunch.
Or to your tables here.
Or to the tables here.
Yeah.
Thanks.
Thank you.